Greetings, everybody. This is Professor Jones, and we're going to get into Chapter 5 of Abnormal Psychology, Somatic Symptoms and Related Disorders, and Dissociative Disorder. The outline for this chapter, or in this lecture, we're going to look at somatic symptom disorder, somatic symptom, illness, anxiety disorder, conversion disorder, factitious disorder, psychological factors affecting medical conditions, and then we're going to look at dissociative disorder, including depersonalization, derealization disorder, dissociative amnesia, and dissociative identity disorder. Some focus questions as we dive into lecture. What are the features of somatic symptom disorder? How are the symptom how are somatic symptom disorder treated? What are the features of dissociative disorder? How do dissociative disorders develop? And how are dissociative disorders treated? Somatic symptom disorder part 1. Types of DSM-5 somatic symptom disorder. We have illness anxiety disorder, we have somatic symptom disorder, we have conversion disorder, or functional neurological symptom disorder, factitious disorder, and psychological factors affecting medical conditions. Soma, meaning body. Preoccupation with health and or body appearance and functioning. No identifiable medical condition caused by physical complaints. These are elements of somatic symptom disorder. The clinical description includes presence of one or more medical unexplained symptoms, substantial impairment in social and occupational functioning, concern about the symptoms, and in severe cases, symptoms become the person's identity. Statistics. Relatively rare conditions, um, relatively rare condition, onset usually in adolescence, more likely to affect unmarried, low social economic status women, and it runs a chronic course. Also, research to date is limited due to the recent redefinition of the disorder in the DSM. So, this is one of those diagnoses that has been updated in the new DSM 5, and newer meaning that it was updated in 2013-14. And there's still research being done today to give us more accurate information about this particular diagnosis. DSM 5 criteria for somatic symptom disorder. Features of somatic symptom disorder include the following: one or more somatic symptoms that are distressing or resulting in significant disruption of daily life. Excessive thoughts, feelings, and behaviors related to the somatic symptoms slash health concerns as manifested by at least one of the following: disproportionate or persistent thoughts about the seriousness of symptoms, high levels of health related anxiety, and excessive time and energy denoted to symptoms health concerns. Although any one symptom may not be continuously present, the state of being symptomatic is persistent, typical more than 6 months, and this comes from the DSM-5. Somatic symptom disorder with a predominant pain. The type of somatic symptoms disorder previously classified as pain disorder. If there's a clear physical pain that is medically unexplained, so this is when people are feeling some type of pain in their body. Little is known about the origin of how this pain has come about or where this diagnosis has come from. And about 5% to 8% of the population may have this actual disorder. So this is the somatic symptom disorder with predominant pain. The causal factors of symptomatic or somatic symptom disorder is little known. We don't really know what causes this disorder. It's a pretty unique one in itself. We don't know what the additional cause is, but some of the speculation is that it may be caused by familial history of illness, stressful life events, sensitivity to physical sensations, and experience struggling. That are benefits to illness, for example, attention. The somatic symptom disorder, also the causes and the treatments. So, some of the best treatments for this are cognitive behavioral therapy, also known as CBT, is one of the best treatments for somatic symptom disorder. It reduces the tendencies to visit numerous medical specialists, AKA doctor shopping. So, trying to figure out which physician is the best fit for yourself. It assigns gatekeeping physicians, and it also reduces supportive consequences of talking about physical symptoms. Let's move to another diagnosis. Let's look at illness anxiety disorder. So, the DSM 5 criteria for illness anxiety disorder includes the following. Features of illness anxiety disorder includes the following: preoccupation with fear of having or acquiring a serious illness. So, you have people who are just like, super paranoid about getting a serious illness. I think COVID-19 can highlight a diagnosis like this where people are like extremely paranoid about contracting the virus of COVID-19. Somatic symptoms are not present, or if present, are only mild in intensity. If another medical condition is present, or there is a high risk of developing one, the preoccupation is clearly excessive and disproportionate. And also, a high level of anxiety about health is included in this particular disorder. So, we have people who are extremely paranoid about contracting disorders. I think one thing to note here also is when people have high levels of anxiety, or people are maybe even be bipolar, um, some of their paranoia and their mania may be associated around things of health, and it can look like illness anxiety disorder. Some other features: the individual performs excessively health related behaviors, such as repeatedly checking their body for signs of illness or exhibiting maladaptive avoidance. Also, they avoid doctor's appointments, which is interesting because you're trying to take care of yourself, but you're not going to the place that could actually diagnose whatever the illness may be. Illness preoccupation also is present, or has been present for at least 6 months, but the specific illness that is feared may be changed. Some of the clinical descriptions of illness anxiety disorder: we have physical complaints without a clear cause of what is going on, like what are you concerned about when it comes to your physical illness. We have severe anxiety about the possibility of having a serious disease. We have strong disease conviction. We have medical reassurance does not seem to help. And also, we are very similar to the DSM-4 hypochondritis disorder, which is no longer in existence. Continued on illness anxiety disorder, we have the individual performs excessive health related behaviors, repeated checks of their body for signs of illness. They exhibit a maladaptive behavior like avoiding doctor's appointments. I feel like I just went over this one. Sorry about that. I meant to go this way. Statistics. We have a prevalence of estimated between about 1% to 5% of people actually will conduct this disorder of illness anxiety disorder. The onset is at any age. The sex ratio is pretty equal, so both male and female identified people and trans identified people can receive this particular disorder. It runs a chronic course, so that means that it's pretty when someone has it, it's pretty potent, and you can definitely identify it. And then also, there's some culturally specific disorders similar to anxiety disorders, which includes Koro, Dat, and Koro Jo. So those are some more culturally specific elements that look like this illness anxiety disorder from different cultural groups. Causes and treatment. Causes: cognitive preconceptual distortions, right? It's something that takes place, which is one of the causes. And then familial history of illness is another one of those causes. Treatments. So there's the challenges in illness related misinterpretations with a lot of treatments. It also provides more of a substantial and sensitive reassurance and education. Stress management and coping strategies are very important here. Cognitive behavioral therapy, also known as CBT, is generally effective, but not always, but generally it can work. And then antidepressants often sometimes are helpful. So antidepressants offer some help in this area, but really it's about managing this person's level of paranoia around illness is extremely important. And here's another motto. As you all are know by now, I'm pretty fond of the models that are produced in the textbook for these disorders to give you a nice visual. So ultimately, someone is triggered by an event or some information, etc. They have a perceived threat, and then that threat goes to apprehension. And then that apprehension can lead to one of these three areas or a combination of the three: increased focus of the body, increased psychological arousal, and checking behaviors to reassurance seeking. That leads to preoccupation of perceived alteration or abnormality of the body sensation, etc. That then leads to a misinterpretation of the body sensations and or signs as indicated severe illness, which then ultimately leads to perceived threat. And the cycle goes on and on and on. And this is the integrative model of illness, anxiety, disorder causes. Let's move to another disorder. Conversion disorder, also known as functional neurological symptom disorder. The clinical description includes the following: physical malfunctioning of sensory or motor functioning. An example: blindness or difficulty speaking. We have a lack of physical or organic pathology. We have persons may show a la belle indifference, and we have a retain, and we also see retain most of their normal functioning, but they lack a lot of awareness in this particular diagnosis. Some of the features of conversion disorder or function neurological symptom disorder include the following: one or more symptoms of altered vocabulary, motor, or sensory function, evidence of the incapability between the symptoms and recognized neurological medical conditions. We have the symptom deficient causes clinically significant distress or impairment in social, occupational, or other important areas of functioning or warrants medical evaluation. So just think about some of these particular issues when you're thinking about conversion disorder. Some of the statistics around conversion disorder are: it's a rare condition with a chronic intermediate course, often comorbid with anxiety and mood disorders, seen primarily in females. Also, the onset is usually in adolescence, so we're talking about young females typically with this disorder, and it's common in some cultural and religious groups. What are the causes of conversion disorder? It's not well understood. The Freudian psychodynamic view is still common, though unsustainable. Past traumas and unconscious conflict is converted to a more acceptable manifestation and example physical symptoms. Primary and secondary gains are features here. And Freud thought that primary gains was the escape from dealing with a conflict. So people were just doing this to get out of other issues that they may have been struggling with. And the secondary gains look at things such as attention, sympathy, etc. Conversion disorder treatments, similar to somatic symptom disorder. If the onset is after a trauma, they may need to process trauma or post traumatic symptoms. We remove sources from the secondary gain. We also reduce supportive consequences of talk about the physical symptoms. Factitious disorder, an overview. The clinical description for factitious disorder is purposely faking physical symptoms, may actually induce physical symptoms or just pretend to have them. And no obvious external gains are shown here. So distinguishing from what's malingering, malingering, uh, which physical symptoms are fake for the purpose of achieving a concrete objective, like getting paid time off, avoiding military service, etc. So this is like a very serious, hyped up version of how kids are when they want to go to school and they're like, "Mom or Dad, I'm sick. I can't go today. I'm sick. I don't feel good." But this is when like it's like a real thing and adults are doing it. Talk about the criteria for factitious disorder. So Some of the features of fictitious disorder include the following: falsification of physical or psychological signs of a symptom, or induction of injury or disease in oneself or someone else, associated with identifying deception. The individual presents themselves to others as ill prepared, unprepared, or injured, or presents another individual victim in this way. The deceptive behavior is evident even if the absent of obvious external rewards. So people are just making up these things about their pain, whether it's psychological or physical, and it's really not clear why they're doing this. So it's a very bizarre disorder, by the way. Fictitious disorder imposed on another. So this is a type of fictitious disorder, more commonly known as Munchausen syndrome by proxy, and it's inducing symptoms in another person. We see this a lot with mothers on their children who end up having this I can never pronounce this one right. Munchausen syndrome. Typically, a caregiver induces symptoms into a dependent. So again, like a mother to a child is like, my baby's sick, my baby needs this help. It's a very bizarre disorder. The purpose of it is to receive attention or sympathy about the particular illness of the other person that the caregiver is taking care of. Munchausen, I think it's Munchausen. Munchausen's symptom. Sorry, I cannot get that out correctly. Psychological factors affecting medical conditions. Are the diagnosis label useful for clinicians? Indicators that the psychological variables may be impacting the German medical issue. And then there's examples of chronic anxiety attacks worsening after asthma or needlephobia, making it impossible to get important blood work done or vaccines for that matter. All right, let's move into dissociative disorders. And here's an overview. So dissociative disorders involve a severe alteration and or detachment from reality. It is the affect identity, memory, or consciousness, and then the interpersonal distortion in particular. The depersonalization, which is the distortion in perception of one's own body or experience, feeling like your own body isn't real. And then we have also a derealization, which is losing a sense of the external world and kind of like living in a dream or a fantasy where you're just like not connected to what's in happening in your own reality. Here are some types of dissociative disorder. We have depersonalization, derealization disorder, dissociative amnesia, where you're losing yourself and you don't remember your memories. We have dissociative trance disorder where you kind of go in and out of these trances. And then you have dissociative identity disorder where you lose your sense of self, and there are other beings or other things that are taking over your identity. You're identifying yourself in multiple different ways. Let's talk about these. Depersonalization, derealization disorder. So, overviewing the features of this is recurrent episodes in which a person has sensations or unreality of one's own body or surroundings. Feelings dominant and interfere with the life functioning. Only diagnosed if primarily problems involve depersonalization and derealization. And the similar symptoms may occur in the context of other disorders, including panic disorder and post traumatic stress disorder. Some of the facts around depersonalization, derealization order are its high comorbidity with anxiety and mood disorders. So those things are usually associated with those two other disorders. Only about 1 to 2% of the population will find themselves in this category. The onset is typically in adolescence. So people who get this are usually in their adolescent years. It usually runs the lifelong chronic course as well. And having a history of trauma makes this disorder more likely to manifest. Here are some additional features of this depersonalization, deregulation disorder. It's persistent and reoccurring experiences of depersonalization, derealization, or both. During the depersonalization or derealization experience, reality testing remains intact. The symptoms cause clinically significant distress or impairment in social, occupational, and other important areas of functioning. The disturbance is not attributable to the psychological effects of a substance or any other medical or psychological condition. Talk a little bit about some of the risk factors and treatments. So the risk factors or causes are cognitive deficiency in attention, short-term memory, and spatial reasoning. We have deficiencies related to tunnel vision or mind emptiness, and such persons are easily distracted. And the treatments for this is little is known due to the limited research. So we don't know what works. Medications are probably one of those things that get introduced. Talk therapy could be one of those things. But if someone's disassociating during a talk therapy session, it can be very difficult to assist that individual. Dissociative amnesia, which includes several forms of psychogenic memory loss. So you're just like spotting out on a memory, like blacking out. And there is a generalized versus a localized or selective type. And also, it may involve dissociative fungi or fugi, which is during the amnesic episode, person travels and wanders, sometimes assuming a new identity in a different place, which sounds bizarre. Unable to remember how and why one ends up in the places that they're actually in. Let's talk about some of the features of this particular disorder. So, with dissociative amnesia, you will see things like an inability to recall important autobiographical information, usually of a traumatic or stressful nature, that is inconsistent with the ordinary forgetting. The symptoms cause clinically significant distress or impairments in social, occupational, and other important areas of functioning. And then also, there's a disturbance in the attributable. There's a disturbance that it. Oh, sorry, let me slow down. The disturbance is not attributed to the physiological effects of a substance, so like using drugs or alcohol, a neurological or other medical conditions, or a different psychological disorder. So these things aren't contributed by people being high or drunk on any drugs. Some of the statistics is usually begins in adulthood, and they show a rapid onset of dysphagia. And then the cause is little known. Like many disorders, we don't know what causes things. We just know what they are when they show up. And trauma and stress are usually severe triggers. Dissociative amnesia also features the following: and the inability to recall important. Wait a minute. That is. I don't know what's going on my slides. I keep going in the wrong direction. Sorry about that. Some of the treatment. So we must get better at people. Most get better without treatment for this particular disorder, and most remember what they have forgotten. So over time, it kind of comes back to people, barring that there's no other interference that may take place. Let's talk about dissociative trance disorder. So the clinical description includes the following: symptoms resemble other resemble. So symptoms resemble other dissociative disorders. Dissociatives are symptoms and sudden changes in the personality. Changes often attributed to the possession by a spirit. So people feel like they're in this trance and something is taking over them. And there's a pre-sensation versus cross culture. So in Nigeria, it's called vice versa, and in Thailand, it's called phi pa, and only considered a disorder and if leads to distress or impairment. So again, this is a tricky one because when you look at different culture groups, there's different ways of looking at spirituality, religion, and other types of systems of connecting with something that's outside of yourself. But in the Eurocentric United States version of psychology, this would lead to a disorder. So what it would end up happening is if you feel like you're being taken over or possessed by a spirit, you can get diagnosed with this dissociative trance disorder. So it's very, very fascinating when we look at it culturally. I don't know what is true and what isn't true. I'm very objective and open to possibilities. Some causes and treatments. Causes are often attributable to life stressors and trauma. As you know, trauma is like a key thing. Life stressors and trauma are like in all these disorders, as you'll notice through most of the lectures for this class. The treatment for this is little known and may need to address stresses and treat and trauma when dealing with dissociative trance disorder. And then did one of the most common dissociative disorders, dissociative dissociative identity disorder. The clinical description is formerly known as multiple personality disorder. Its defining features is dissociation of personality, adoption of several new identities, as many as 100, and maybe just as a few, on average 15. Now, this is due to case studies where people have many different identities. There's a lot of examples. You can actually check this out on YouTube, where people have multiple personality disorders. Very fascinating. The identities display unique behaviors, voice, and postures that are identified by each kind of alter of possession. So, what's are some of the unique aspects of dissociative identity disorder? You have alters, which are different identities or personalities. So it's the same body, different personality. You have a host, which is the identity that keeps other identities together. So it's usually what the who the person really is. So let's say Professor Jones has did, and I have three other identities. My host is Professor Jones, but I can have Bobby, Sasha, and Mark. Those can be three different alters that I shift through. And then you have a switch, which is the quick transition from one personality to another. Some of the statistics of this is the ratio of females to male is pretty high. So more women have dissociative identity disorder, a 9-to-1 ratio. The onset is almost always in childhood and adolescence. So you notice these things early. High comorbidity rate and it's lifelong. And then there's also chronic course as well. So this diagnosis is usually combined and connected to another one, and it's more common than previously thought. The thought used to be that not a lot of people had this, but we know about 3% to 6% of the population has dissociative identity disorder. Um, Dissociative identity disorder continued. Here are some of the features, and include the following: a disruption of identity characterized by two or more distinct personality states. The disruption or marked discontinuity in sense of self and sense of agency, accompanied by the related alterations in affect, behavior, consciousness, memory, perception, cognition, or other sensory motor functioning. The recurrent gaps in the recall of everyday events, important personal information, and or traumatic events that are inconsistent with ordinary forgetting. Also, the symptoms cause clinically significant distress or impairment in social, occupational, and other important areas of functioning. The disturbance is not a normal part of broadly accepted cultural or religious practices and is not attributable to the physiological effects of a substance or other medical condition. There used to be a show called United States of Terror. It used to come on Showtime, and if you have a Showtime subscription, or it might even be on Netflix, it's a really interesting show where it goes over this person's life, and they have DID, this social identity disorder, and it just kind of gives you a good example and a viewpoint of what someone who lives with that disorder goes through. Let's talk about causes. So typically it's linked to a history of severe and chronic trauma, as I've continued to state, often abuse in childhood. It's closely related to PTSD, possibly an extreme subtype. The mechanism of escape from the impact of trauma, and then the biological vulnerability is also possible for the causes of dissociative identity disorder. Here are some of the treatments: a focus on reintegration of the identity, so trying to get those identities to connect back to that host, identifying and neutralizing the cues and triggers to provoke memories and the trauma slash disassociation, and then the patient or client may have to relieve and confront the early traumas. Some achieve this through hypnosis. So, trying to get people to deal with those things that have ultimately led to the diagnosis of dissociative identity disorder. Talk a little bit about false memories. So this is fairly easy to create false memories through suggestibility. The interest in repressed memories has led some patients to thinking that they have repressed memories of abuse, which are later shown to be false, but can be very damaging to the patient and their families. And then therapists need to be well trained in memory function and be careful not to suggest an untrue history by mistake. So when we're dealing with people with dissociation disorder or somatic disorders, their memories can be pretty faint. So we have to kind of be very careful on what we're attaching ourselves to and what we're not, because what we're hearing may be from a place that is not true, but we need to do our due diligence as professionals to help. So, in summary, the somatic symptom disorders and dissociative disorders. The features of somatic symptom disorder is physical symptoms without an organic cause, and the features of dissociative disorders are extreme distortions in perception and memory. Well established treatments are generally lacking for these two disorders, and there's a lot of room to grow and understand here. So if you found this chapter to be very interesting and you are interested in even helping and working with individuals in this area, this may be a place of study for you as you continue your educational journey, because there's just a lot of gray area and things to know. And on that note, we are going to end this lecture, and I'll see you in the next one. Peace.